Well, hello to everybody out there. Welcome to this Boston Children's Hospital webinar from the Department of Cardiology and Cardiac Surgery. Um, we are representatives, both cardiologists and cardiac surgeons from the Departments of Cardiology and Cardiac Surgery. My name is Wayne Toretsky, and I am the director of the Fetal Cardiology Program. I also do general cardiology. And my colleague in the white doctor's coat is Dr. Fernando Barona Reyes, who is also a cardiology colleague who specializes in adult congenital heart disease. We have also from our Department of Surgery, Dr. Rami Mani in the jacket and tie, all the way from, he's currently at a conference in Mumbai, India. It's 7 p.m. there. And we also have Dr. Chris Baird, also from our Department of Cardiac Surgery. Both of them are cardiac surgeons who specialize in children with heart disease at all ages. I will give a brief introduction on the topic of Ebstein anomaly. It's the main topic of this webinar today. I just want to preface everything by saying that we will not be giving specific medical information or advice in questions that may be sent in the Q&A, but we are happy for you to contact us and obviously try and help you or give you advice about the best places for care for your child or a patient. So I'll give a brief overview. Ebstein anomaly is a heart lesion of the tricuspid valve, and that's the inflow valve to the right side of the heart, connects the right atrium to the right ventricle. It's a heart problem that has varying severity. It can be very mild, and some people don't even know that they have it or are diagnosed as adults, and can be very severe. That is first diagnosed in utero. And it's a problem where mostly the septal leaflet, the one that's attached to the ventricular septum, is stuck down, and that results in leakage in the valve. That valve leakage can lead to right heart dilation of the right atrium and the right ventricle, and that can lead to clinical problems such as heart failure, low oxygen levels, and it's a very broad spectrum of problems that can occur in this disease. In general, the earlier you're diagnosed in life, meaning the earlier you're diagnosed in gestation, the worse the disease, meaning if you're diagnosed in utero because your ultrasound shows that the heart is very large, that usually means it's a much more serious form of this problem. And then we have some babies with less severe forms of the disease that can diagnose at birth because they have a heart murmur or they're blue, or sometimes we even see teenagers or adults who, for the first time, get diagnosed because they're short of breath with exercise, or someone notices they have a large heart on X-ray. So I'm going to start out, seeing that I'm the doctor that deals a lot with fetuses and neonates, to talk a little bit about the problems that we see. So we get, it's a very rare condition in general, and the severe form, the fetal form, is also quite rare. And it's one of those problems that can result in problems with the pregnancy. Babies can be born prematurely. And of course, when we have a premature baby that's born with this problem, they can be very sick. So they need to be at a major cardiac center, either such as ours or many others around the country and around the world, because it requires specialized care to take care of these children. The ones that have the severe form in the fetus and in the neonate often require a form of surgery. And so maybe I could start with Dr. Baird to talk about the patients that are born often between 35 weeks and 40 weeks full term, who often have a very, very large heart and may have unstable circulation, low blood pressure, low oxygen levels, and the different ways that we can stabilize these babies.
Thanks.
and maybe the surgery, the different surgeries that can be offered.
Thanks, Dr. Turetsky. So, um, first off, at Boston Children's, we have a cadre of surgeons. There's about 8 or so neonatal surgeons, and Dr. Amani and I have a particular interest in a number of subsets of patients, and Ebstein's being one of them. So we've taken on this interest over the last number of years with Dr. Turetsky to really focus on children with Ebstein's anomaly. And I think there are several centers around the world that have had this focus and interest, and we work along the same lines with the same goals and agenda. And ultimately, our goal is to delay surgery in the neonatal period if we can. But on the other hand, I think what's really critical is not to delay too long, and that can be a mistake if you're trying to push through and delay surgery and the baby is marginally stable. So what we've tried to do is work with our ICU team, and we've developed now an ICU team that really helps us with the cardiologist and Dr. Turetsky manage from really prior to the baby being born to birth and delivery straight to the ICU. And then we critically join forces with all of those teams, cardiology, ICU, and surgery, to make a definitive plan frequently early on uh, to whether it's to go to the operating room or perform some procedure in the ICU for stabilization. And that period is very critical that all of the team members have discussions around and are on the same page. And in surgery, it's really important that we have not just one person that focuses on this, but more than one. And as pointed out, Dr. Amani and I have taken on that interest because that allows us to have different insights and opinions rather than just relying on one team member. So, having said that, if the baby is stable, then frequently we can work through the neonatal period and get out of the neonatal period without surgery, and then ultimately become discharged. And then Dr. Turetsky can follow that patient, and then we can come back in the coming months to even years, and then potentially, do the more definitive operation of the cone procedure. We can talk about that in more detail later. But in the neonatal period, if we're in extremis, in other words, the saturations are low and the baby's having a struggling time, then we will go to the operating room. And in that period, we've learned over the years there are a number of approaches to be able to manage these babies. And we've done all the approaches, and that experience has given us a lot of insight into what we can do, should do, and can get away with, from the neonatal cone experience to the Starnes procedure to now what we think of as a little bit called the modified Starnes procedure, to get us through that neonatal period in a safe way. And what that involves is going to the operating room and patching over the tricuspid valve, but importantly, leaving the tricuspid valve so we can go back and use that tissue later to reconstruct the valve. And then providing a source of pulmonary blood flow, whether that's a shunt or more frequently, we've been doing a somewhat of a hybrid approach with our catheterization doctors to provide maybe a ductal stent to try to minimize the risk of having a shunt and having to do that up front. So, to summarize that, there's a sequence of steps we go through. We get through that operation, we come back to the ICU and micromanage that patient for the next 3 to 4 to 6 to 8 weeks to get them to the next phase and ultimately discharge from the hospital. So I know that's kind of that neonatal phase of potential intervention and surgery. And Wayne, maybe I'll kick it back over to you now.
Yeah.
And
Maybe I
Yeah.
could
So
just, if I
go
can,
ahead.
just clarify one thing. Um, you talked about a lot there, and maybe we could just clarify. So this Starnes procedure, what exactly is the goal of that, Chris? Maybe we could just kind of pause for a second and sort of say there's a really subtle strategy. We're trying to really protect that tricuspid valve for a later repair. But in the meantime, with the Starnes procedure, what you're trying to do is to get the left ventricle to really do all of the work for both pumping to the body and to the lungs. So you're not relying on that right side to pump the blood into the lungs, which would require a good tricuspid valve. And this tricuspid valve in a newborn or a really young child may not be able to push that blood forward. And so all of the strategies with this are to use mostly the good left ventricle to pump that blood. I think that's just a point of clarification. I'm sure a lot of people know about that, but for those that don't, I just wanted to kind of clarify that is what that strategy is meant to do.
And
Yeah.
along those lines, to follow up, I called it the modified Starnes versus the Starnes. It's just the Starnes procedure originally was where you put a tube in, a Gore-Tex tube, as the shunt for pulmonary blood flow. The modified Starnes, as we've defined it, is you actually can avoid that step and use the patient's own ductal tissue and prostaglandins in the early phase to help limit the risk of the operation per se, and then come back. So the modified nature of that refers to what we're doing with pulmonary blood flow portion of the procedure.
Yeah, and that's just really because sometimes these shunts are at risk for clotting, and we want to try to avoid that with using that native tissue, which is the connection between the aorta and the pulmonary artery, and try to control that so that we get just the right amount of blood flow, but not have the risk of clotting, which is something that people have seen when they've done the traditional Starnes procedure.
Yeah, so here our surgical team have been talking about the most severe form of the neonatal Ebstein anomaly, the patients who require the Starnes operation, which is really a life-saving operation. Our approach to these neonates, no matter how sick they are, how low their oxygen levels are, is still initially to try and be patient and let the natural transitional physiology take place. Some of these patients who may appear to have very severe Ebsteins, if we're just patient with delicate and attentive ICU management and the use of all medications we have now, such as nitric oxide, can sort of more normalize their physiology and avoid surgery in the neonatal period. So we don't want to create the impression all the babies need it, but we're talking about the ones with the most severe form. The critical period for these patients is really the last, say, 6 weeks of pregnancy and the first 6 weeks of neonatal life. That's the critical time when they can get sicker as neonates, as fetuses, and then in the neonatal period where we have to make these critical decisions and whether that sometimes the patients need surgery, sometimes even ECMO, which is basically mechanical support for their circulation. So those are the critical time periods. And then a lot of these patients, once they get out of the hospital from the neonatal period, we can plan surgery later on, more definitive surgery. To add to what Dr. Imani said, the one encouraging thing about Ebstein anomalies is that your main pumping chamber is the left ventricle, which is the stronger ventricle that's meant to pump to the systemic circulation. And that's why we focus on going to these measures to get the baby through, because we can come back later on and address the right ventricle and try and modify the surgery and involve the right heart in circulation. Excuse me. What is Dr. Imani, what's the reason why we cannot repair the tricuspid valve in the newborn period?
Yeah, that's a great question, Wayne. I think we like to repair valves when we can, and I think our strategies for repairing valves have really gotten better over time. But the issue in a newborn child is the valve tissue is really soft. It's really fragile. And if you try to repair it, there's a chance that that repair can tear through. And we've also found that trying to do a complex valve repair in a young child, the right ventricle isn't really prepared to handle that. And so we found that it's better to let the right ventricle mature a little bit, let that valve mature a little bit, and then come back and do a repair. So doing something to initially get a stable circulation, let a child get out of the hospital, feed and grow, And then we come back at a later time to do a valve repair, and whether you need to do this Starnes procedure first or whether you can get by without any operations, it doesn't mean that we can, stop following a child. But I think if you're watching that ventricle carefully, you can come back and do an operation later. And that's what we're always trying to think about is how do you get the best long-term outcome? How do we get the best long-term quality of life and activity?
So Dr. Barona Reyes, uh, this entity of Ebstein anomaly is not just the valve tissue, but often these patients can have a form of cardiomyopathy, which is that the heart muscle didn't develop normally, both in in the fetus, the neonate, and in the older teenager and adult patient. And that can be challenging in that it's not just the valve, it can be the heart muscle, and they can have rhythm issues. I don't know if you'd like to address some of the issues related to that in terms of the heart muscle and rhythm issues.
Yeah, thank you. Yes, I think that's most we know more about this disease. This is different with other type of valve disease. It's just related only to the valve isolated problem. Here is a combination of both. The heart muscle most of the time is tend to be weak and weaker, and it tends to deteriorate the heart function over time. In addition to the leaky valve because of the Ebstein anomaly. So that's a difficult situation. That's why we most of the time we need to go proceed with more advanced cardiac techniques in order to get a better diagnosis and get a better a sense of what the status is. So we start with echocardiograms, but most of the time we need to go continue with a cardiac MRI. I think it will provide more detailed information, particular in terms of the heart function of the right ventricle. And then most of the time we need to proceed with a cardiac catheterization in order to get full hemodynamic evaluation before to make a final decision in terms of when to intervene. That's the thing that is, since we know more and we are more aware because of the combination of called like heart failure and plus the valve regurgitation, right? That we're now more recently, we are shifting our indication for going for surgery. Back, I would say 10 years ago, we waited until patients were more symptomatic, when we already were established heart failure symptoms or signs that are failing our heart, right? So now we are trying to be more proactive and take a couple of steps ahead in order to prevent the already established heart failure symptoms, because we know that the prognosis is worse when we wait too long. And the other part of it is also associated with this is it comes with arrhythmias. Sometimes patients may have an accessory pathway, so tend to have rapid arrhythmias like fluttering in the heart coming on the right atrium. So when they are symptomatic with arrhythmia, we need to look specifically where this accessory pathway is, doing another test called electrophysiology study, and try to localize, and sometimes they can burn right where the accessory pathway is. But also, if we are thinking about going for a COM procedure, for example, even those patients who are asymptomatic, we may need to also perform electrophysiology study in order to make sure if there is an accessory pathway like it's hidden, and we don't want it to be symptomatic after the surgery.
Thank you. That's a nice overview. So what I want to ask our surgical team is that, of course, we always desire to perform a complete repair where the patient has all the blue blood going through the right heart, all the pink blood going through the left heart. But sometimes, as Dr. Barona has alluded to, is that the right heart can be weaker, the heart muscle and the size of the ventricle. Maybe Dr. Imani can talk about the 1.5 ventricle repair, where we incorporate the right heart into the circulation, but not the full circulation, and how that has some advantages potentially in this disease.
Yeah, thanks. I think this is a really important question. So, your child or you have survived the childhood phase, and now you have Ebstein, and we're trying to decide on when do you do something. I think that's one question. But when it comes time to do something, we prefer to repair the tricuspid valve. But sometimes if that right ventricle just isn't strong enough, we need to offload it a little bit, give it a little bit less work to do. And so one of the things that we'll think about at the time of surgery to fix the tricuspid valve is to decide whether or not we want to unload the right ventricle a little bit by taking some of the blood flow coming from that upper body and directing it directly into the lungs. That's something known as a Glenn procedure. And that just allows less blood to go through the right side of the heart and makes the right side of the heart work a lot less. And so this is something that we're going to think about as we're talking about needing to address the valve. And Dr. Broner has just kind of mentioned a little bit about the timing, but Wayne, I'm curious to get your sense of, so when you've gotten past that childhood phase, when is it that we want to do something on this valve? When is the best time?
Well, so of course, if the patient is, of course, in the pediatric world, if the patient is not growing well, doesn't have adequate saturations, or is symptomatic from heart failure, which often goes along with growth, that's time to intervene. And like many heart defects, we don't necessarily intervene immediately always. And the timing is always a good question, but I think the general principle is that if the patient is not thriving, certainly in the pediatric world, probably in the adult world, they look more at heart failure symptoms, and but for us, and then there's that fine balance of the strength of the tissue for the surgeon to operate on. And so I think, because we've had these discussions many times, I think where if the child is growing, but we know that obviously long-term the heart is going to be affected by this. I was thinking more around age 3 or so that, again, you could discuss the integrity of the tissue in terms of operating on this delicate valve tissue. But I think there are no real strict rules in this because every patient is slightly different. But in terms of repairing the valve, that's, I guess, a question I could throw back to the surgical team. What age is it that you like to do the cone procedure where you think the valve tissue has enough strength to it?
Dr. Baird, do you want to, you looked at this in a recent study.
Yeah, so actually, if folks are interested, we did a publication out of the institution here in Boston about looking at this question about time and integrity of the valve and the ultimate longer term outcomes. And essentially what would be best for the child. And what we found is, in a general sense, earlier is better. But we like to coordinate that with what Dr. Turetsky's talking about. It's kind of based on symptoms and the echo and the anatomy that goes along with it. But if the child has any symptoms at all, we feel that earlier is better. You can think of a couple of years, 3 years in that range. And again, you're welcome to take a look at the publication. There's several out there that kind of give you the details if you're interested, in more specifics about those patients and the group we're talking about. But I think once you reach over a year old, certainly over 2 years old, that tissue is, I would say, much easier to handle. And we can divide that tissue, we can move the tissue, and we can do the so-called cone procedure much easier. The tissue's less delicate per se. So I think it's really important to go on the symptomatology, but even beyond that, as the heart continues to grow and anatomically we begin to go into heart failure, I wouldn't be nervous to go sooner rather than later.
I might actually take that to the next level, Dr. Baird, and say that even in a patient who doesn't have symptoms, if you have leakage of that tricuspid valve, severe leakage of that tricuspid valve, if you can fix it adequately at a young age, why wait for problems to develop? And I think this has been one of the one of the shifts that we've had over the past several decades as we've gotten good experience with this cone repair is that it's now been such a standardized procedure, and we know it has really good outcomes. So rather than waiting for the atrium to enlarge, arrhythmias to develop, symptoms to develop, and now make the operation a little bit more difficult, why not do it before we get into trouble, as soon as the valve is healthy? And in your study, it sort of came out around 4 years of age is a really good time in that late childhood phase. If a patient has severe leakage, you know is going to develop heart enlargement over time. I would argue better not to wait for symptoms to develop and try to do it at a younger age when the outcomes are better, and you're less likely to need that 1.5 ventricle approach because the right ventricle hasn't really tired out quite yet.
Yeah, I agree. That's a good point. It's actually nice time to kick back to the cardiologist here and talk a little bit about the longer term complications that one might have to deal with, in particular the arrhythmias. I don't know if Dr. Turetsky or Barona-Reyes wants to comment.
Yeah, Dr. Barona-Reyes, maybe you can talk about first the indications for surgery in your older patients or teenagers and young adults, how you make the decision to send them for surgery, and what things you look out for in following them.
Yeah, thank you. So when we do find that it's at least moderate to severe leaky valve, in addition to symptoms, meaning shortness of breath, exercise intolerance, having palpitations, or there are some rare patients that also may get bluer, right? It's called cyanosis, because they also may have an extra hole or a shunt inside of the heart. Those will we think are patients that we need to consider surgery, right? So in addition to that, patients who are asymptomatic, they don't have any symptoms, but we still see the leaky valve is at least moderate to severe, and we see with several testing that the heart sizes keep growing, enlarging over time, even without symptoms. That's another indication for going for surgical repair right now. In order to prepare surgery, even they may have symptoms like arrhythmia, like fluttering sensation or palpitations, or they may not have any symptoms at all. Sometimes we do find some signs on the EKG that may guide us to see this patient may have this accessory pathway. That's called the Wolff-Parkinson-White syndrome. When there are symptoms with it, we should go for an electrophysiology study before going for surgery. Why? Because we want to make sure that the accessory pathway is going to be hidden by the way the surgeon they fix the valve. They're going to be possible later to get into the accessory pathway, maybe hidden under the tissue of the heart.
That's a good, there's one question in the chat that maybe I'll bring up. It seems like a good time for that. The question in the chat is, what is the incidence of WPW, Wolff-Parkinson-White? And that's basically this accessory pathway that develops that can create an arrhythmia. What is the incidence of that, and how does that impact our management? And my understanding, if I can take a crack, and curious to see what others think, it's about 10 to 25% of patients with Ebstein anomaly can have WPW, and an accessory pathway or a hidden or concealed pathway can be in up to 30%. But you can have multiple accessory pathways as well, and up to 30 to 50% of patients who have that WPW. So this is something that's really important for us to look at. And how do you typically treat a patient if you notice they have that condition, and how do you diagnose that condition?
Well, we can actually start out in fetal life. They can get arrhythmias as well, and that's actually very high risk if they have a very big heart. And it's actually surprisingly uncommon, even though the heart is very large. We have seen patients with arrhythmias and severe fetal Ebstein anomaly, and then we treat them with medications in utero for that. In the neonatal period, we start with medications, but very occasionally we have to do a EP procedure to ablate the arrhythmia, but probably the more important and more common ones are in the older patients. As Dr. Barona-Reyes said, we routinely, before the cone procedure, do an EP study to try and unmask any rhythm issues, and then we have the surgeons or combined with the electrophysiologists treat that or cut the pathway. They can also get other arrhythmias, not just WPW, which is an accessory pathway, because the right atrium is often very large and stretched. It can damage the tissue and cause other type of rhythms as well. So
yeah, that was the second question. Another question in the chat about SVT, supraventricular tachycardia. And the question there was, if SVT does show up, does it mean something? And is that an indication, perhaps, that you need to proceed with an intervention, but either surgical or ablation?
Yeah, atrial arrhythmias are very common in Ebstein's anomaly. Not only Wolf Parkinson-White, it could be another like SVT, atrial reentrant tachycardia. And one of the reasons is because of the right atrium is so large, right? It's under a lot of stress because of the reflux from the tricuspid valve. So yes, it's very common. There's another indication when a patient having a lot of arrhythmias over time to go for a surgical repair. And fortunately, these are called like benign type of arrhythmia. It doesn't impact the heart function if they went treated on the right time.
There was maybe we can address a couple of other questions that came up in the chat here. One question is, can Ebstein's patients take stimulants?
Yeah. I think it's really on a case-by-case basis. I think if a patient actually has active, poorly treated arrhythmias, then we try and avoid anything that has any stimulants. But I think really this is on a case-by-case basis, depending on a specific patient. There's another question there that says, are there any advancements being made in the standards of care for in utero diagnosis? So what we're using, which is, of course, standard ultrasound and echocardiography, but also we're using a fetal MRI as well, not just to look at, specifically in Ebstein's, looking at the lungs, but also just for other potential anomalies, congenital anomalies, which can occur. There can be some associated genetic issues in Ebstein's. Again, most don't have that, but we have seen patients with other chromosomal and genetic issues. So that's in terms of diagnosis. In terms of management, for people out there who have been using Google and reading things about the fetus and the neonate, there's a thing called a circular shunt. And that is when the pulmonary valve is still open, but the right ventricle is too weak to pump forward across the pulmonary valve. The ductus arteriosus, the blood vessel connecting the pulmonary artery and the aorta, the blood flow is reversed in that. And so instead of going forward from the right side to the left side, it goes from the left side to the right side. And when the pressure is very low in the right ventricle, the blood can go backwards down the pulmonary valve and then again out the tricuspid valve because there's tricuspid leakage. And that's called a circular shunt. And the problem with that is that the blood circulates around inside the heart, but doesn't really go enough. There's not enough blood flow to the organs of the baby. And so think of it like an irrigation system that has a leak. It's ineffective, the blood flow. And so a lot of the circulation is being wasted.
Yeah, Wayne, if I can just chime in there,
Sure.
That's a really important point, and I think a marker of severity, particularly in the neonatal period. So we really take a close look at this so-called circular shunt. And I think that takes a real team effort and a relatively aggressive surgical plan to really stop that shunt, because these neonates, after they're born, they can really decline very quickly if you're not on top of that. So it takes a really astute clinician and a group of ICU doctors, cardiologists, and surgeons ready to intervene to manage that. I think that's an important point in the very early period in the high-risk patients.
Yeah. And that even before that, when the baby's still in utero, there is one medication that we can give that can reduce the amount of circular shunt, and that's a medication called non-steroidal anti-inflammatory drugs. That's something that people take for headaches and back pain, and that actually has a side effect in the fetus that can cause constriction or narrowing of the duct. And so we use that in selected cases. If the fetus is getting sick or heart failure in utero, we'll use that to reduce the circular shunt. That's certainly something that have to be involved at a center that is used to taking care of many of these patients. So that's just one other thing to add in the fetal management. So arrhythmias can get treated in utero, potentially reduce the circular shunt, plus using more imaging techniques for trying to
Wayne,
risk stratify.
Can I just go back briefly, because we've gotten a number of questions on this and historically about, from your standpoint as a fetal cardiologist, and very specifically this idea of management in the fetal period to really try to get on top of this disease. Just talk about a little bit about what some of those options are. You alluded to it a little bit here, but I know there are families that are very interested that have a fetus with Ebstein's. What can we do early on in the fetal period?
Yeah, right now we haven't done any fetal procedures per se. We have done other types of fetal cardiac interventions, but certainly we have some ideas about things to do. But right now, really focusing on mostly medical therapy and either preventing arrhythmias or treating arrhythmias. Sometimes we see patients that have sort of an irritable heart, lots of premature atrial contractions, and we'll often in that situation, we might preempt the arrhythmia by giving medication for that. But really right now, it's only medication and close observation. And of course, the timing of delivery is an important thing as well. And that's often controversial, where we want to keep the baby in utero as long as possible, and the obstetrician's always worried about, fetal demise. So it's what I call in utero ICU management, where we're seeing these patients often twice a week and trying to time the delivery perfectly. Of course, they also will get steroids to try and mature their lungs, and obviously good nutrition for the mother. But at this point, it's really trying to manage this pregnancy and try and get them as far as possible. One of the problems with these babies who probably have low cardiac output in utero is that they can get acidotic. So often they're born and they have high lactate, and they're just really in sort of a low form of cardiac output, which is because of this abnormal circulation. So, timing of delivery is critical. And then, of course, the perinatal management and good ICU management initially is absolutely critical for these patients. So again, I get back to that critical period of the last 6 weeks of pregnancy and the first 6 weeks of neonatal life is absolutely critical in having delicate and attentive management.
Yeah, go ahead.
Oh, and as we are talking about pregnancy, I want to bring another aspect of the disease.
Yes.
That we do also take care of young women who wish to become pregnant. So our role in the adult congenital heart program here is to try to perform a detailed cardiac evaluation to try to stratify what are the potential risks for that woman getting pregnant or will go through the pregnancy. Most of the time, there are arrhythmia issues. That's something we need to evaluate carefully, be related to the hormone changes and all the volume changes normal during pregnancy. But fortunately, it depends what the type of severity of the Ebstein is. But most of the time, women can get through a pregnancy and delivery very safely, but should be under specific and specialized care.
So there are some other questions here, which may be for Fernando Barona-Reyes, about the prognosis for adults in their 30s and 40s with a cone procedure. Of course, it probably depends on when you had it and how good the surgery was, but in general, I think because the cone is relatively new, meaning probably the last 2 decades, there are many patients today who would get their cone procedure earlier, but many also were getting it later. So if you want to address patients who have the cone procedure when they're in their 30s and 40s and sort of the challenges with that.
Yeah, I think one of the there are two things that we need to follow up after the surgical repair. One is how the status of the valve repair is. So may tend to have again a leaky valve over time, and we need to follow when it be the right timing for doing another operation, right? And the other important part is what is the status of the heart function. I think mostly heart failure symptoms, how we got it with new medication that we have that we learn from the adult world, right? In order to to try to improve the heart function over time, that's going to be driven the long-term complications.
I would say
Maybe
that we looked at the incidence of reintervention, and it's very low, especially with the new cone procedure under 10% in the long run, and most of that is sort of in the more severe form. So I think one of the lessons learned was that trying to do the operation before it becomes a severe case is always better because that reduces the stress on the valve and makes it more durable. And I think, at least in my opinion, I've generally tried to to do it on the sooner side if we know that it's severe and there's atrial enlargement or the heart's enlarging some. Um, there's a question about treating individuals with Ebstein and trisomy 21 or Down syndrome. And I think in those patients, we try to avoid doing the Glenn procedure as a special case. So that's one of the special considerations that we might take for a patient with Down syndrome.
so. I know we've been talking about the cone procedure a lot. Dr. Imani, would you like to just spend a few minutes just describing what the cone procedure exactly is, why it's
Sure,
called the
there have been
cone,
a lot of procedures for repair of Ebstein anomaly over time, and in the past, the surgeries were not as durable. With the cone procedure, what we're doing is we're essentially rotating valve tissue in such a way that it completely covers the bare area where there wasn't valve tissue before. So part of the heart that's called a septum typically has valve tissue there, but in Ebstein, that valve tissue is very displaced and essentially not present. And that's where the leakage comes from. So we want to put more leaflet near the septum. And the way that we do that is to take healthy leaflet tissue from the rest of that same valve, the tricuspid valve, where there's plenty of tissue located, and just rotate to fill that gap. And that's what the cone procedure is. And in most patients, we're able to do it all with native tissue. So that means we're not adding any additional prosthetic material, which I think is always good because that means that that valve will grow and behave normally over time. In an adult patient, we'll also do ablation or cryoablation to get rid of any arrhythmia circuits. And we'll usually use a ring to support the repair, and that's really helped increase the durability of that. We rarely find that we need to do the Glenn procedure at the time of the cone, and that's something that is different in our institution compared to others that have done it. Some places routinely do the Glenn procedure, and I think we found that we haven't had to do it all that often, but it's something that might need to be done at the time of that cone procedure to unload that right ventricle, as we talked about earlier.
Well, there's another two interesting questions there. The one is regarding tricuspid valve replacement, which obviously in some cases one might need to do, which obviously is a little more complicated, but more interesting. Somebody asked a question about the potential for partial heart transplant, which is perfect for Dr. Imani to answer, whether that's something you've thought about. I don't believe we've done that, but is that something you think is a possibility in the future, partial heart? And just to describe what that is.
Yeah, so a partial heart transplant or a valve transplant is where you take valve tissue from a living donor and a heart that's not being used for a regular heart transplant. You take that valve tissue and use it for replacement or repair of a child's valve. I think that's a very viable strategy. We're doing that now, and it's something that I think is has a role. My opinion in Ebstein, however, is that there frequently is enough leaflet there that the cone procedure is sufficient. I haven't seen a situation in which there wasn't enough tissue, but in the situation where there isn't enough tissue, this would certainly be an option.
I think
And
just another comment on that. To go along with that, I think there was a question here. How do you know when the cone will not work when the valve tissue's gone too far? That's pretty rare, I think, to say, as Dr. Monty pointed out. Usually there's a fair bit of tissue there. It's the way you have to remodel and rearrange it. So to answer that question, almost all patients who have Ebstein's are amenable to a cone procedure or even a modified cone procedure. And sometimes, if there's not enough valve tissue, you can use a patch. And again, this may be an area where donor partial heart transplant may come in to the picture. If you need a portion of the leaflet or a patch of the leaflet right now, we frequently use the patient's own tissue, such as pericardium, to do that. But at the end, what we may find is that donor tissue or that so-called partially heart transplanted tissue, if we need a patch or if there is deficient leaflet, may be an option in the future.
yeah, the next question is about right ventricular dysfunction after repairing a valve. I think this is really important, brings us back to the question of timing. Trying to do a procedure before right ventricular dysfunction develops is really important. So that's one of the reasons why we're trying to do this procedure on the earlier side before a patient develops heart failure. But if there is right ventricular dysfunction after the surgery, we're first looking at how does that impact the heart function. In other words, are the pressures in the heart adequate? Is the heart otherwise functioning well? Sometimes just medication management to make sure that the right ventricle is in its spiphious shape is all that's needed. So far, we haven't had to go back and do a Glenn procedure, but if there is a lot of right ventricular dysfunction, that is an option. We could go back and unload the right ventricle a little bit by doing the Glenn procedure, the 1.5 ventricle repair that we talked about to unload that right ventricle further. And finally, one could go in and create a connection between the right atrium and the left atrium, a small hole that allows some decompression if we needed to in order to treat right ventricular dysfunction. So if we see right ventricular dysfunction, we have a couple of things that we can do, and we have a multidisciplinary approach where we have our cardiologists, surgeons, catheter doctors, and advanced cardiac therapy teams to help us manage.
So
I
there's
think
a
there's
okay,
a
go ahead, Chris.
Yeah, I was going to say there's a question that's somewhat related here in regards to Ebstein's and congenitally corrected transposition. I think a lot of times the patients with congenitally corrected transposition are often said to have Ebstein's, and frequently it's not necessarily Ebstein's, it's a tricuspid valve dysplasia per se, which frequently requires tricuspid valve intervention and some of the elements of the cone procedure. But is it true Ebstein's? Not frequently. It's not that it never occurs, but the point is that frequently with congenitally corrected transposition, you need a tricuspid valve repair that, yes, sometimes has some of the elements of the cone procedure. And if it truly is Ebstein's, occasionally you'll require a cone procedure with the other elements of repairing congenitally corrected transposition.
Yes, there's another whole complicated subsection of Ebstein that we haven't addressed yet, but that's another sort of rare version of Ebstein where the heart is twisted the other way. The right and left ventricles are on the incorrect side, and that can be associated with Ebstein anomaly as well. And that's an even more complicated surgery and probably a topic for a whole nother session on corrective transposition.
Yeah, there was a question about after a Starnes procedure and what's next. And one thing I want to say is that just because someone may have had a Starnes procedure doesn't mean that we can't go back to repairing the valve. We've done that in a number of patients and have been quite successful at doing that. And the question is, are those patients at a higher chance of needing a Glenn? And I think the answer for that is probably yes. So for specifically patients who had really severe forms of Ebstein in the neonate and had to have a Starnes or modified Starnes, coming back to have a repair, we'll make the assessment. We're not going to do it off the bat. Make an assessment, decide if that right ventricle can handle a full flow. If it doesn't, then unloading it with the Glenn would make sense. But a clone procedure can be done after a Starnes procedure, and so we try to do that if we can.
Yes, I agree. I think that's a relatively new approach at our center and other centers that specialize in this, that the so-called 1.5 ventricle repair, which is really the Glenn plus the cone procedure, and to use the right ventricle in the circulation.
There was one question. I'm sorry if I can jump in.
Yeah.
There was a question about heart block in Ebstein's. So with the repair, can you get disturbance of the rhythm and need a pacemaker? The incidence of needing a pacemaker with Ebstein in our experience is again very low. It's probably somewhere around 5% or less. One of the things that we've developed over the past several years to try to reduce the rate of heart block is something known as intraoperative conduction mapping, where we can actually use a conduction catheter to identify the location of the electrical system and try to avoid injuring it during the repair. And that's something that we'll frequently use now to help us with the repair. And I think that's been quite helpful at reducing the risk of needing a pacemaker.
Yeah, there's some questions about sort of heart failure, right ventricular dysfunction. So maybe Dr. Barona-Reyes can talk about what different medications we have. If the right ventricle, which we've already stated, often has dysfunction, maybe even some form of cardiomyopathy, we can offload the ventricle using the Glenn. But what other medications do we have, either to lower the pressure in the pulmonary arteries or to help the right ventricle squeeze better?
Yeah, that's I think is a difficult question. Unfortunately, the medication that we know that help for the left ventricle does not all of them work the same way for the right ventricle. So yes, we try, if there is evidence of volume overload, if you have extra fluid in your body, we use diuretics, for example, like water pills. There is a specific one called like the family from spironolactone. They also help try to reduce the inflammation and fibrosis inside of the heart. There's a new medications called SLTG1, or two medications that are called like empagliflozin. That's also have shown benefit in the heart function and also reducing the extra fluid. And when this is a combination with elevated pulmonary pressure, we also use pulmonary vasodilator therapy. But it's hard because not all the time they respond the same way to the left ventricle.
Okay. Yeah, well, thank you. I don't see any new questions coming in here, but this is a discussion that can go on for hours because it's such an interesting topic. It's a heart problem that we have a lot of work to do on, and we are actually doing a lot of work, innovating, doing research, and because it's a rare disease. We have one of the advantages being a large cardiac center is that we get, even though it's a rare disease, we do get a lot of patients with this disease. And so we're able as a team to make progress on the management of this, both all the way from the fetus to the adult, with often surgery in between. And we will continue to do that. So if people have specific questions, people out there listening, you could use this email address to send us questions. We'll obviously try and help you. We can't give medical advice specifically on this webinar, but we're happy to try and help you navigate with your children or your patients. Thank you to my colleagues, Drs. Baird, Imani, and Barona-Reyes, and for the Children's Hospital team for helping to put this webinar together. And I'd like to thank you all for attending, and we're happy to help in the future if you'd like to contact us. So again, thank you everybody for your attention, and my colleagues for participating.